Just say welcome to everybody that's joined to the tier 2 of the ORBCoN CBS serology workshop. Um, we will just give a few minutes for to make sure that all the participants that are going to be here are going to join. Then we'll get started probably around 2:05 for some last minute water bathroom breaks if needed. All right, Tracy, okay if we get started?
You betcha.
Perfect. Welcome everybody to the ORBCoN CBS serology workshop, dry workshop, tier 2. For those of you joining back from tier 1, thanks for returning. And for any of you who are just joining us for tier 2, welcome. My name's Jonathan Mack. I'm a medical officer with CBS and Medical Services and work with the diagnostic lab there as well. And also a transfusion medicine physician and hematologist at the Ottawa Hospital. So we'll be going through the questions and suggested answers with some discussion around each of the questions for the cases that were sent out as part of the workshop materials. Kind of general approaches, we'll go question by question, read the question, go through what the responses from the groups were, and then some of the key concepts and suggested best response for the questions. We, I think, have enough time, or should have enough time, to allow some discussion after each question or as each question's kind of being discussed. So if you have questions or comments, just feel free to just raise your hand or to put the comments into the chat, and we'll try and get to it as each question is kind of being discussed. So with that, I guess we'll get to it. So the first case, case 1, is a 73-year-old male patient admitted with septic shock and started on broad spectrum antibiotics. And the patient has historically typed group A, RHD positive, with no previously detected RBC antibodies. An antibody screen is performed and shown below. So we have the antibody panel here. So with question 1 is what test should be performed next? The options being an antibody panel, direct Coombs test, absorption and elution, or repeat antibody screen with a longer incubation time. So when we look at the panel, what are we seeing on the panel, or what are we seeing on the screen? So we're seeing no reactivity at immediate spin or Coombs phase with any of the 3 screening cells. But the patient's autocontrol is positive with IAT and negative at immediate spin. In terms of responses that we got on this one, direct Coombs test was by and large the most popular answer, 129 people picking that one. An antibody panel being picked by a few people, and absorption and elution being picked by a few people as well. And then some minority of people thinking antibody screen with a longer incubation time might kind of resolve the problem. So what are the concepts involved in this one? What are we seeing as abnormalities? As we highlighted, the antibody screen is negative, but the patient's autocontrol is positive. The patient doesn't have a known transfusion history, so we can trust that the autocontrol is picking up some reactivity with the patient's own cells, and not be worried that there might be some allogenic cells or other person's red cells that are circulating and causing the positive autocontrol. So this kind of a pattern, when we would see this, would really kind of suggest potentially a drug-dependent antibody or something that's unique about the patient's cells that's causing antibody to react with them. But we'd want to confirm that that this autocontrol is actually showing us some antibodies that might be present coating the patient's RBCs, which would be accomplished by doing a direct Coombs test or a DAT as a way of confirming the autocontrol. So that's the best answer for this question would be to go ahead and do the direct Coombs test and confirm that there's some antibody coating the patient's red blood cells. It's similar information to what the autocontrol would give you. You might think, well, why would you need to do that if the autocontrol is positive? Like, haven't we demonstrated that the patient has reactivity against their own red blood cells? But it does provide a bit of different information in that it's showing us that there's antibody coating the patient's RBCs, not just that the patient's plasma is able to react with their RBCs, which is slightly different. Gives us a bit more of a sense of how much reactivity is going on in vivo rather than just in vitro. In terms of other answers that are on there and why they're maybe not as good an answer, an antibody panel, wouldn't really necessarily help to resolve the problem that we have here, which is that there's some autoreactivity that's being demonstrated. We do have 3 screening cells that are negative, so that's kind of reassuring that there aren't any alloreactive antibodies. You might argue that doing a panel might help to show us if there's alloantibodies that aren't present, but that really wouldn't kind of explain why just the autocontrol is positive and not any of the screening cells. So the antibody panel is probably not going to give us a lot of useful information. The absorption and elution would be a reasonable test to do, but we haven't demonstrated that there's actually any RBC or any antibody coating the RBCs yet. So until we do a direct Coombs test and know that the direct Coombs test is positive, the absorption and elution wouldn't be the right immediate next step. We'd want to sort of confirm that there is actually antibody coating the red blood cells before we go ahead and do the absorption elution. And then finally, repeating the antibody screen with a longer incubation time. Well, there isn't really any reason to suspect that the negative reactions we're seeing are due to a problem with incubation or an antibody that's maybe not going to have as high or be as high affinity or need some extra kind of time to incubate and cause some problems. That really wouldn't kind of resolve what we're worried about here, which is potentially a drug dependent type antibody problem. So not something that would resolve this kind of problem that we're seeing here. So the direct Coombs test kind of being the first next step to confirm what we're seeing with the autocontrol. Question 2, no reactions are observed on a 10-cell panel. So that was done and we don't see anything on it. So a negative panel that was using the patient plasma, nor with an eluate that was prepared from the patient's RBCs. So both those tests were done and didn't provide any additional information. Direct antiglobulin testing is positive, with 3+ on the polyspecific, 3+ on the anti-IgG, and negative with anti-C3. The question is, what is the most likely cause of these findings? The options being clostridial infection, piperacillin tazobactam, cold agglutinins, or vancomycin causing the problem. So in terms of responses, Majority of people went with pip/tazo as being the likely cause of the findings. A few people picking vancomycin as the next popular answer, and then almost split between Clostridial infection and cold agglutinins. Some people being unsure. So what's the concepts behind this? Well, again, as we kind of touched on a little bit in the discussion of question 1, is that the suspicion, most high suspicion here should be for a drug-dependent hemolysis. And the reason for that is because of the negative antibody screen, but with a positive autocontrol. So there's something unique about that, the patient's cells, or the cells we're taking from the patient, that something in their plasma is reacting with only their cells and not anybody else's cells. And when you see that kind of a pattern, that's really suggestive that there might be some kind of a drug the person's taking, or something that's in their own plasma that's coating their red cells that then is allowing an antibody to react with it. And that you can really be sure of that as in situations where you know there's no transfusion history. Obviously, if there's been a transfusion history, then that changes the thinking quite dramatically, and you're a little bit more worried about this being more of actually a delayed hemolytic reaction, or something related to those red cells that have been transfused now enters into the realm of possibilities. But in this case, where the transfusion history was negative, a drug-dependent type process is going to be the most likely. And it's a bit of a shifting kind of epidemiology in terms of which antibiotics or which drugs are most commonly associated with drug-dependent hemolysis, as practice patterns in terms of which drugs are used have changed. One of the more recent reviews came from the Garrity lab, where they looked at samples they'd received and reported on the frequencies of different drugs that they found implicated in drug-dependent hemolysis. So this is over 10 years ago now, so may have shifted a little bit, but probably not by a lot. And what they found was that antibiotics as a class were one of the most frequently implicated drugs, with piperacillin, beta-lactamase inhibitors, and cephalosporins, particularly ceftriaxone and cefotetan, as being the medications or the antibiotics that are most frequently causing drug-dependent antibodies. Non-steroidal anti-inflammatories, particularly diclofenac, were seen next most commonly. And then in the anti-neoplastic drug category, a chemotherapy called oxaliplatin was seen third most commonly. So those would be sort of the big categories of drugs to think of if you're worried about a drug-dependent hemolysis or drug-dependent autoantibody being formed. And just as a reminder of how these drugs can cause and why they're drug-dependent, and why we would be seeing this kind of a pattern where the screen is negative, but the patient's own cells are reacting with their plasma. It's, again, goes back to this idea that these are drug-dependent antibodies, and so the antibodies that are there need the drug to be present coating the patient's RBCs in order to react for most of them. And so that can happen if there's an antibody to a drug that's bound to the red cell surface, or and the antibody is actually directed against the drug itself, or the drug binding to the red cell membrane might cause some kind of a conformational change in the red cell membrane that wouldn't be present otherwise. So when the drug is not present, those parts of the membrane aren't exposed, and so the antibodies can't bind. But when the drug is present, that part of the membrane gets exposed, and you now have antibody binding. Or it could be that the drug and the red cell membrane, or part of the red cell, form a complex, and an antibody is then directed against not just the drug and not just the red cell membrane, but directed against the two of them together. So there's some of the possible mechanisms that have been proposed to explain some of these drug-dependent autoantibodies, with support for all of them. And so that's why with the screening cells in these cases, since the screening cells don't have the drug being incubated with them, and they're not going to have the drug bound to their surface, and then therefore shouldn't react. Unfortunately, not all these cases read the textbooks, and so you do see occasional cases of drug-dependent hemolysis where the screening cells are positive. So it becomes a little bit harder to be suspicious of a drug-dependent process in those cases. But if we're seeing a screen that's negative with a positive autocontrol, and can confirm there's no transfusion history, then that really becomes the most likely possibility. So getting back to our question, just thinking about the epidemiology of things, of the options that we see here, pip/tazo and vancomycin both being drugs, and so both being kind of likely to explain things. But piperacillin tazobactam, of these two options, is the one that would be seen more commonly. And we haven't really seen reports of vancomycin causing drug-dependent hemolysis specifically, and sometimes cause problems for platelet antibodies, but not so much red cells. Just in terms of the other options that were there, they're not completely crazy. Clostridial infections have been associated with hemolytic reactions. So patients with clostridial sepsis can often have pretty profound hemolysis going on, but it's not an immune type hemolysis. We wouldn't be expecting to see auto antibodies with clostridial infection related hemolysis. And cold agglutinins obviously can cause hemolytic anemia and hemolysis, and that would be positive on a Coombs test, but we'd often expect these to be IgG negative and C3 positive, so sort of the opposite of what we're seeing with the Coombs test here. So that makes the cold agglutinins less likely in this case. Question 3, same patients, red blood cells are requested for transfusion. Would it be okay to issue a cross-match incompatible unit given that the pre-transfusion test results? So there's a positive DAT, there's an auto antibody reacting with the patient's cells, and so given that, if we're ready to issue a unit but it's cross-match incompatible, would it be okay to issue that unit? So option A is yes, we can issue the unit because this antibody is not associated with hemolysis of allogeneic red cells. B, no, this antibody is associated with hemolysis of allogeneic red cells. C, this antibody is not expected to interfere with cross-matching and other alloantibodies should be excluded. Or D, this antibody is only expected to be significant at cold temperatures. In terms of responses we got for this, bit of a mix. Some people thinking this antibody is not associated with hemolysis of allogeneic red cells, so going ahead and issuing the unit. Most people thinking this antibody is not expected to interfere with cross-matching, and so alloantibodies should be excluded, and this incompatible unit should not be issued. And then a few people thinking this antibody is associated with hemolysis of allogeneic red cells, and so shouldn't be issued. So concepts behind this one. So again, I should maybe worded this question a little bit more carefully about which antibody we're talking about, but it's meant to be the antibody we're seeing on the auto control, so the drug-dependent antibody. So best answer here is that this antibody is not expected to interfere with cross-matching, and so we should be excluding other alloantibodies and not releasing this unit. And I think just important to emphasize that these drug-dependent antibodies they're going to be different, even though this is a DAT positive case. This is not the same scenario as an autoimmune hemolytic anemia, where we might actually feel comfortable releasing a cross-matching compatible unit because that's expected with the autoantibodies. In a case like this, where we see the screening cells are negative, we have a 10-cell panel that's negative, we know that there's no, or we've demonstrated that there's no reactivity between the patient's plasma and other red cells that haven't presumably been incubated with the pip-tazo. In this case, it's sort of the likely suspect. So we shouldn't be seeing cross-matching compatibility due to that drug-dependent antibody. You know, the red cells that are being cross-matched haven't been incubated with whatever drug the person's reacting with, the pip-tazo. And so we shouldn't be seeing any cross-matching compatibility. So we should really be raising our eyebrows and saying, well, what's going on with this cross-matching compatibility? And is there something that's being missed on the panel and on the screen, a low-frequency antigen this person's developed an antibody against? And we should not be issuing this incompatible unit, which is in contrast to what we would do with a regular autoimmune hemolytic anemia. In terms of the other answers, just a few things to mention on these. So this antibody is not associated with hemolysis of allogeneic red cells is true about the drug-dependent antibodies. For the most part, they don't lead to hemolysis of allogeneic red cells, and that's because they're not going to be the targets of the red cells. So even though that's a true statement, the concern here is that we've got a cross-matching compatible unit, which raises the possibility of an undiagnosed alloantibody. So even though this is a true statement, the latter part of this, we still need to kind of make sure that we're figuring out why this unit cross-matching compatible. So that's why that's not a good answer. Is this antibody associated with hemolysis of allogeneic red cells? So it wouldn't be, as long as they're not coated with drug, and so that is true. But we shouldn't be issuing, or we still shouldn't be issuing this unit. So sort of the first part is true, but the second part's not great. And then option D, is this antibody expected only to be significant at cold temperatures? Well, that's not true of these antibodies. They're not necessarily cold reactive only. They can react at any range of temperature, and often do react at body temperature if it's causing especially if it's causing a clinically significant hemolysis. So that one's not true. So those are the concepts behind question 3. So that's it for case 1. I don't know if I can just take a pause there and see if there's any comments or questions about that particular case, or if we're okay to move on. I don't see anything in the chat.
No hands raised or questions in the chat so far.
Perfect. Move on to case 2. So this is a 72-year-old woman who's admitted for emergency hip surgery after a traumatic fracture. And she has a history of coronary artery disease with bypass grafting 8 years earlier. And her pre-transfusion testing is shown. I think we're going to go through, we'll take a minute, I guess, just to go through the interpretation of that. So what are we seeing on the pre-transfusion testing? So if we look over at her results, she's got reactivity that's showing up only with the panel cells. The autocontrols are all negative. And there's no immediate spin activity, but there is reactivity at the Coombs phase, and that reactivity goes away with Fison completely. A titer is done of this antibody with cell 1, and we can see that it's reacting 1+ across all the titers, but reacting all the way out to a titer of 1024. The question is, which of the following is most likely to be true? Transfusion of red cells expressing the antigen to this antibody will cause a severe hemolytic reaction. The pattern is likely due to multiple alloantibodies. Pre-warming the sample will result in a negative panel, or donor plasma will likely neutralize the observed reactivity. In terms of responses we got, it was a pretty good mix of answers. So almost evenly split between donor plasma neutralizing the observed reactivity and thinking the transfused red cells with whatever this antibody is reacting to will cause a severe hemolytic reaction. A few people thinking that pre-warming the sample might result in a negative panel, and some people thinking the pattern is likely due to multiple alloantibodies. So what's the approach to this one, or kind of what are the key concepts here? So we're seeing low reactivity, panagglutinin, so whatever it is kind of probably a high frequency antigen, and it's really kind of like solid reactivity across the board. There's no variability really in the testing. So this is kind of a point against this being multiple alloantibodies, where we'd often be seeing 3+, 1+, 2+, 3+, some variability in terms of the strength with multiple alloantibodies. This looks like it's all one and the same antibody reacting similarly with all of the antigen, or all of the cells that are being tested. So this kind of argues against there being multiple alloantibodies and probably more one antibody with one specificity. It's an enzyme sensitive the antigen it recognizes as enzyme sensitive because Fison treatment makes the reactivity disappear. And it's a very low avidity but high titer. So it's titering all the way out to 1024. So these are what used to be commonly called a high titer low avidity antibodies, or HTLA antibodies. So these are sort of groups of antibodies that share these common kind of properties of being very high titer. When you titer them out, they just persist and persist and persist. You can't make them dilute out, but they never really react all that strongly. That's where the name comes from. And some of there's a pretty big group of antibodies that behave this way. Some of the most common ones I've included here. So Chido, Rogers, Cost Sterling, York, Knops, McCoy, and John Milton Hagen. They're not, as a group, usually clinically significant, although that's obviously none of these antibodies always follow all the rules, but in general, HTLA antibodies are not clinically significant, so not likely to cause a severe hemolytic reaction. They're problematic really because they can conceal underlying antibodies. You might miss reactivity because these are acting sort of like the autoantibodies do in autoimmune hemolytic anemia, where you've got a panagglutinin, so you can't rule things out because of that. Their sensitivity to enzymes or DTT really depends on the antibody that the specificity that they're showing. So most of them are going to have some sensitivity to Fison, where they'll be decreased with Fison treatment. Some of them decrease with DTT treatment. And then the Cost Sterling one that is unique in that it doesn't really get affected by either of them. And then a unique feature to the Chido and Rogers system is that pooled plasma can neutralize them. So if you mix pooled plasma with the patient's serum, you can make the reactivity go away, so it can resolve it. That's really specific to the Chido and Rogers HTLAs. So if we go back to question one, the best answer here is that donor plasma will likely neutralize the observed reactivity, and that's again because we're thinking this is an HTLA, so Chidos and Rogers might be the reactivity there. Question A is not a great one because most of these do not cause severe hemolytic reactions. We talked about the pattern, how it's fairly consistent across the whole panel at a 1+, so making multiple alloantibodies less likely. And then pre-warming the sample is probably not going to cause a reactive panel because we don't think this is a cold antibody that's interfering with things. Although I guess I should say on there that pre-warming can make a lot of stuff go away, so you should be careful about pre-warming things if you don't think there's a cold antibody there, but not a great answer. So it might actually be true, but not a great answer for this question. So question 2, which antibody specificity is least likely? Options being anti-Chido, anti-NOPS, anti-little e, or anti-JMH. And most people here answering anti-little e. A few people thinking anti-Chido might be the best answer. It's one of these annoying questions where it's the least likely, so I'm not sure if that explains some of those answers there. And then a few people thinking anti-NOPS or anti-JMH as being the possibilities. So most people getting the right answer here, which is anti-little e. So these are all high-frequency antigens, so little e being present on most people's red cells, and same with the Chido and NOPS and JMH. So reasonable to think all of them could be possible targets, but the similar strength against all panel cells and some of the panel cells then being little e negative, you wouldn't expect there being that much of panagglutination. And then the reactivity that's absent after enzyme treatment really argues against these being an anti-little e specificity. Little e really shouldn't be reduced after enzyme treatment. If anything, it would be enhanced. So the enzyme treatment really argues strongly against this being an anti-little e specificity. So same case now, this patient undergoing, different case, case 3. So I tricked myself there because they're both having hip replacements. Any questions, comments on case 2? Don't see any, so just move on with case 3. So case 3 is a 77-year-old woman who's undergoing elective hip arthroplasty, revision. She's already had one arthroplasty, now it's being revised. And during the initial arthroplasty, she's received 2 units of RBCs, so she does have a transfusion history. The results of the pre-transfusion testing that are sent on the pre-op sample are shown. And so what are we seeing on this sample? So we see on the forward typing that she's typing as a group A on the front type, and she's typing as a group A on the back type. And she's D positive at a 2+ strength. And when we look at her panel, we'll do a little bit later, we can go through it right now. We're seeing some reactivity here at the Coombs phase with cells 1 and 2 and cells 4, 5, and 6. No reactivity of other cells. So which of the following is least likely to explain the patient's pre-transfusion results? What we're seeing on the panel. So an auto anti-D antibody, auto anti-LW antibody, an allo anti-D, or an anti-C antibody. So in terms of responses we got here, most people are going with the anti-C antibody, and then a bit of a mix between some of the other options, almost evenly split between them. What's the rationale behind this one, or what's the approach to this one? So first, let's look at the specificity of the antibody. We didn't do that earlier. So the patient is is positive with anti-D, so looks like she's an A positive patient, as we highlighted earlier. And when we look at the antibody panel, if we go through our rule outs, we can exclude most antigens or antibody specificities except for a big E or a D. And when we look at the reactivity, we're seeing 1+ with both D positive cells, and these 3 cells are all D positive. So every time D is there, we're seeing reactivity. And we can't rule out big E just because we haven't tested enough cells. Every time big E is there, D is also there, except for this one here. So we've got 1, but this is a heterozygous cell. So we'd like to see kind of 1 more big E to rule it out, but it really looks like a D specificity. So there's a bit of a disjunction here with the patient being RHD positive, but having made an apparent anti-D antibody. So when we look at the options here, anti-C antibody is the best answer, partly just because it doesn't have any big C specificity. We've ruled out a big C here with this panel. And then in terms of a patient being D positive and making an anti-D, all three of these would be potential explanations for that. So patients can have autoantibodies that have a D specificity or an apparent D specificity. LW as a system is very similar to RHD, and expression in adult cells at least is very closely related to your RHD expression. So RHD positive adult cells will have high LW expression, and RHD negative adult cells will have low LW expression. So you can kind of get mimicry of a D specificity with an anti-LW antibody. And then an allo anti-D antibody is a possibility as well, even though this patient is D positive. We don't know if she's a D variant. She could be used to be called a partial D and missing part of the D antigen, and then making an allo anti-D antibody if she with her prior RBC exposure. So that big C antibody is the best answer in this one. Question 2, the autocontrol and direct Coombs test are both negative. So which of the following will most likely help to identify the antibody? So our options here are repeating an indirect antiglobulin test using DTT treatment, indirect antiglobulin testing against an R prime or R double prime cells, indirect antiglobulin testing against ORHD positive and ORHD negative cord cells, or either A or C. So in terms of responses here, bit of a mix. I think most responses clustering on either A or C. Some responding the R prime or R double prime cells is the second most common, and then DTT treatment or cord cells individually as answers. So when we look back at this and we think about what the specificity is, so it's an anti-D specificity in a D positive patient. And so again, we went through some of the possible explanations, which would be an auto anti-D antibody, a D variant, sort of the typo there with alloimmunization, or an auto anti-LW. And so a little bit about the LW system. So the LW system used to be called anti-RH when it was first discovered, before it was recognized that it's actually a separate antigen system from the RH system. And as I mentioned, it's got a relationship with D antigens. D negative adult RBCs show low expression of LW, and D negative cord RBCs show strong expression of LW. So we can use cord cells that are D positive or D negative as a way of differentiating an LW from an anti-D, which would be one of the objectives in this patient, given that there's an LW or some kind of an anti-D antibody as possibilities. So the cord cells would help, because if this antibody is reacting with D positive cord cells and D negative cord cells, that would suggest it's more likely an LW. Whereas if we see only D positive cord cells and not D negative cord cells reacting, that would suggest more of a true D specificity rather than LW. The other approach to differentiate them would be to use DTT treatment. So LW is destroyed by DTT, but RHD shouldn't have any, it shouldn't impact RHD at all. So if reactivity is going away with DTT treatment, then that would fit with an LW specificity, not a D specificity. And just a bit about the expression of LW and why there's these autoantibodies that can be seen is that the LW expression can be reduced in pregnancy, certain types of cancers, which can then lead to an autoantibody being generated. So kind of an apparent autoantibody in someone who shouldn't be able to make an antibody otherwise. So when we combine that with question 2, the possible response for question 2, you can see that DTT treating would be helpful because that would allow us to distinguish LW from D specificity. And similarly for option C, because the cord, as I said, the cord cells, if they're reactive with cord D positive cells, but not D negative cells, and that would fit with D reactivity, and reactivity with both RHD positive and negative cord cells would fit with LW specificity. So those two would both help us to differentiate the two. Indirect antiglobulin testing against the R prime, and R double prime cells wouldn't really help us differentiate much here, because it's these cells that are little r are going to be low in their D expression. They have no D on them, so they will have low LW expression. And so if it is an LW specificity rather than a D specificity, these cells won't really help us to solve that, because they'll be low in LW, so would expect it to be sort of low, not reacting with an anti-LW, and wouldn't react with an anti-D either. So not going to help us much with with what we're trying to answer with this question. So the results of the additional testing is shown, and I have to highlight that there was an error made. My apologies for anybody who lost sleep or had stress trying to answer this question with this cell 3 being reactive. This should be zeros, not 1 pluses on this table. So the table should be 1 plus 1 plus, and then no reactivity with the cell, and then 1 plus 1 plus, similar to the first panel, just with the DTT treatment, sort of showing persistence of the reactivity afterwards. So my apologies on that. So that's what we're seeing with DTT treatment, is persistence of the reactivity. And then on the cord cells that were tested, we're seeing adult O cord cells reacting, O positive cord cells reacting, O negative cord cells not reacting, and a similar pattern being mirrored in the adult cord cells reacting with D positivity, and cord O positive cells, but not cord O negative cells reacting, so mirroring the adult reactivity that we're seeing. So what specificity is this most consistent with? Anti-LW, anti-big C, an autoantibody, or an anti-D antibody? So most people got this one right. It's a anti-D specificity with 92 picking that one, a bit of people picking some other answers, the anti-LW. So if we go through here, the fact that that this is still reacting after DTT treatment really rules out an LW, and that's further ruled out here by the cord reactivity we're seeing. So the O negative cord cells, these O negative cord cells will have LW expression that's high, so these should be reacting with anti-LW specificity. So we can rule that out with these two results. We're not seeing weren't seeing any autoreactivity that was mentioned, so no reason to suspect that this is an autoantibody, and we're not seeing the pan reactivity we expect with an autoantibody. So that kind of makes an autoantibody less likely. So this is really looking like D specificity that we're seeing here, which would be the best answer here. And we're not seeing this big C specificity, so that's not something that's showing through. And in fact, we have some cells that are big C, one cell that's big C homozygous that doesn't react, so we can rule out a big C antibody. So that's question 3. For question 4, which of the following is the most likely phenotype predicted by genotyping? So options are being weak D type 1, weak D type 3, weak D type 4.2, or weak D type 2. In terms of answers here, most people went with weak D type 4.2 for this one. Bit of a spread around some of the other weak D types, type 1, 2, or 3. So what are the concepts involved in answering this one? So D epitopes. So this gets back to RHD variants. Again, we have this patient who's D positive, who's made an apparent D antibody, and so how could that be? Well, they must be an RHD variant if that's happened, and truly be sort of a so-called partial D and missing part of their D. So what are the RHD variants? So D variants as a group are D epitopes that are either altered or decreased in their density on RHD positive RBCs, and the are sometimes called partial D if they're missing parts of the epitopes or some of the D epitopes, but not all of them, and so they still will test D positive with certain reagents. Or a weak D, where the density of the D antigen is decreased on the outside of the red cell surface, and so depending on the anti-sera that's being used, may type negative. And so serologically, they could be, there's a lot of variability, again, depending on which reagents being used. They could be negative, weakly positive, or just strongly positive for D antigen. And there's a risk of alloimmunization, but it depends on the D variant in question. So for any of you that were there for Tier 1, where we talked about prenatal testing and the importance of genotyping, that's again why this is important. You want to know what the exact variant is, so you sort of know what the risk of alloimmunization is. And in general, weak D types 1, 2, and 3 are the weak D types that are not considered at risk of forming anti-D. So again, with the caveat that a lot of these things don't always read the textbooks, these are the weak D phenotypes that are generally not considered to be at risk of forming anti-D. And so when we get back to this patient who's formed an anti-D and who's D positive, they're suspected to be a D variant. But of the options here, types 1, 2, and 3 are not at high risk of making anti-D antibodies, which this patient has done. So she's likely going to be a type 4-2, at least of the options that were put into the question. So that's kind of the rationale behind that question. So I think with that, that's the last of the question. So I guess just open it up to the chat, or if anyone has any comments or questions for this part of the workshop.
So again, if you have a question, you can raise your hand and I will unmute you, or you can put it into the chat function and we will be able to read it out and Dr. Mack will be able to answer it for you. You explained it so well. You don't have any
Hey.
questions.
Super. With that, I guess if there's no questions or burning things, we have I think the next seminar is scheduled to start at 3, and just because of not everybody's doing all the same sessions, so we do have to kind of respect the timing of things. So I guess we'll close out this session. I'll just thank everybody for for the participation in the workshop. It was nice to go through all the different answers and to kind of informative to kind of go through the experience myself. So thanks a lot for the participation and for joining today. And I will see some of you for tier 3, which is starting at around 3 o'clock. We'll probably do the same thing. We'll wait till about 3:05 for people to show up, or give a bit of a grace period. So try your best to show up for 3, but a bit of a grace period at 3:05 will start. And yeah, if there's any other questions or follow-ups, I guess you can direct them to myself or Tracy. Thanks a lot.